Welcome to The Backstory with Dr. Ricky Singh. This podcast is focused on bringing you the latest research-based information about dramatically improving health, well-being, and quality of life. And here's your host, Dr. Ricky Singh.
All right, welcome to The Backstory, and today we are talking with an expert in aging. You know, for many of us, aging is inevitable. It's just a part of life. And I am certainly guilty of using terms when I speak to patients such as age-related wear and tear, when I talk about joints and spine and muscles, and maybe I shouldn't speak that way. Maybe it's kind of pejorative to just assume that we are all deteriorating. And I wanted to discuss today, does it have to be this way? Is aging really just a natural process? Should we accept it? Or can we kind of hack this? And my guest today is going to share his thoughts on this very topic. He is the Distinguished Professor of Medicine at the Weill Cornell Medical College and Co-Chief of Geriatrics and Palliative Medicine and the Director of Geriatrics for the New York Presbyterian Healthcare System. He is also the former president of the American Federation for Aging Research. So I'm very excited to bring on my good friend and my colleague, Dr. Mark Lachs. So Dr. Lachs, welcome to The Backstory.
Thank you for having me, Ricky.
So tell me a little bit about you. Tell me about your training. You know, many doctors who complete internal medicine residency end up pursuing things like cardiology or nephrology or something like that. But you went on to pursue additional training in geriatrics. So what is geriatrics? What does that actually mean?
Well, geriatrics, like the term pediatrics, refers to the clinical care of older adults. The same way a pediatrician cares for your kids, a geriatrician cares for older adults, sometimes confused with the term gerontology. Gerontology refers to the study of aging, and a broad category of people call themselves gerontologists. Psychologists, people who study housing, transportation, sociology. Insofar as that I do research and take care of patients, I respond to both. But my primary role is as a geriatrician, that is, an internal medicine physician who subspecializes in the care of older people, namely geriatrics.
So what actually happens in the human body as we age? Does the medicine change? Do some medicines that used to work at a certain age stop working? Do you need different strategies? Is that why we need specialization in geriatrics?
The issue of medicines is a separate podcast, Ricky, because as we age, we metabolize medications differently. Medications interact with food and alcohol. The target organs become more or less susceptible to medication. So we can spend a lot of time talking about that. In general, the process of aging begins in utero, right? There's a normal process of human physiology unfolding, and we tend to think of childhood and adolescence as normal phases of aging. And I think of geriatrics as part of that human development. You wouldn't think of adolescence as a disease. You wouldn't think of childhood as a disease. We shouldn't think of aging or our older years as disease. That is what we call ageist.
Right. So, and I want to touch on that. You know, one of your colleagues who sits on the American Federation of Aging, David Sinclair, wrote this book called Lifespan. And you know, he talks about aging as the disease, you know, rather than saying arthritis is a disease or Alzheimer's or disc degeneration, things that I focus on. And I kind of just assume, okay, patient, you're going to get some of these issues because of age. But he suggests maybe it doesn't have to be this way. Maybe age is itself the disease and we need to combat that. How do you respond to that? What do you think about that notion?
So David is a friend and a colleague. You've just touched upon sort of the really sort of metaphysical sort of discussion now in aging, which is aging a disease? I tend to disagree with that idea. I think that there are diseases that are more common as we age. And I think that if we could slow the process of aging, we would slow the onset and severity of those diseases. But since you're a physiatrist, I will tell you the apocryphal ageist joke that geriatricians often tell. Morris Smith, who's an older man, goes to the doctor and he says, "Doc, my right knee hurts." And the doctor says, "Well, Morris, how old are you?" He says, "Well, I'm 96. And he says, "Well, what do you expect at your age?" And Morris gets up somewhat indignantly and he says, "Doc, the problem with that explanation is that my left knee is also 96 and it doesn't hurt at all." Right? So that's sort of a funny joke, but it's meant to demonstrate an idea, which is physicians often misascribe, aging as disease. And in that case, Morris might have had something treatable. He might have gotten his knee injected the way you've injected mine on several occasions. So it sends a terrible message to patients when we just say you're getting older. It says go home and sort of shrivel up, and I don't look at it that way at all.
And that brings us to a point of a term called medical ageism. Just like you mentioned, where many conditions and ailments suffered by elder adults. I used to say old people. I don't say that anymore. I say elder adults. Kind of go untreated or not treated because we just expect it to happen, just like you mentioned. A little more than a decade ago, you wrote a book called Treat Me, Not My Age. And in your book, you said, it doesn't have to be this way. We should treat the patient as an entity and not just a number. Tell me about this book. Tell me about what you were researching and what were your findings.
Yeah, well, we have a saying in geriatrics, you've seen one 85-year-old, you've seen one 85-year-old. They're all different, right? And Ricky, you take care of 85-year-olds who are playing doubles tennis, who could whip you at bridge. And I take care for 85-year-olds who are bedbound in a nursing home, right? So there's an enormous range of abilities of people who are older. How you take care of yourself during your young adult life with regard to health habits, but also the kind of care you get has enormous impact on that. So there is ageism in medicine. There is a tendency to not do things in older people simply because they're old. So, very often I'll see an older person who's been denied an angioplasty or a surgical procedure that they might really benefit from. And we call that undertreatment. I want to get a geriatrician angry at you, tell him or her you won't put a stent in their 90-year-old patient simply because they're 90, right? Now, that's the kind of undertreatment problem, but there's another side to that, and that's the overtreatment problem, the kind of cookbook medicine thing where everybody with a cholesterol of X needs Lipitor. Older people get into trouble because meds are prescribed injudiciously. So I like to tailor the medicine to the functional abilities of the patient. And that's where you and I overlap. We are interested in function, right? People come in all upset about an MRI they got and of their knee or their hip. And you and I know there's no such thing as a normal MRI once you get to be 40 or 50. And so we need to think about the abilities of the person to carry on their daily activities.
That brings us to a question that I struggle with. I want to say this properly. I have young 80-year-olds. I have older 80-year-olds, and some of them need knee replacements who still play with their grandkids, who still play golf and tennis. Yet they are often denied knee replacement surgery because of their age, because of their medical comorbidities or non-modifiable risk factors such as age. But going back to the question of the young elder adult and the older elder adult, how can we hack this? Is there a way that living through our 30s, 40s, and 50s can kind of build up or modify our epigenetics to protect us in the long term?
Oh, I think it's quite clear that, as we age, Ricky, we sort of lose what's called physiologic reserve, right? And in your 20s, 30s, and 40s, you just don't notice it because there's so much excess. You and I know you spend the first year of medical school learning how the good Lord gave us too many nephrons, too many neurons, too many lung cells. We have many more cells than we need, 2 kidneys, 2 lungs. Have you ever asked yourself, how is it you can take out a kidney in a young person or an older person and they simply function very well? And the reason for that is that whether you're a believer in creationism or evolution, we were programmed to survive to childbearing age, right? And after that, it really didn't matter what happened to you. You had to survive smallpox or being skewered by a wild boar as a hunter-gatherer, and just have kids so that the species could continue. Now, that occurred when life expectancy 1,000 years ago was 20 or 30. We go back 100 years, it was 60. Now it's 80 or more. And so we live needing this reserve. And how you take care of yourself in your 30s, 40s, and 50s, exercise, nutrition, we'll talk about epigenetics, really makes a difference. It's really quite important. So during your 30s and 40s, unless you're a NASA astronaut who has your lung capacity measured or a starter for the New York Yankees who has their fastball clocked, you don't realize that your body is slowly sort of slowing down because there's so much reserve. But when you get to 70 and 80 and you can't make those stairs or your reaction time is slowed, that's when you begin to realize that, what did Mickey Mantle say? Had I known I'd lived this long, I would have taken better care of myself.
That's right. It's interesting about life expectancy. It wasn't even 1,000. Just 100-something years ago, the average life expectancy was 36. And now we're, just like you said, close to 80. Now, a lot of that was due to, the medical advancements and infant mortality and things like that, vaccines. You mentioned smallpox. And I'm no stranger to this. Just a few weeks ago, the residents invited me to play basketball with them, and I was sore for a good 3 days, and it was very embarrassing. And I couldn't go back the next week because I felt my age. And I hated to say that. I'm 40 years old, and my joints and ligaments told me, you were once prepared for this type of activity and you went into it a little too fast. So what are some of those tools? You mentioned diet and exercise and sleep and stress. One of the topics that comes up a lot in my practice in physiatry is something called sarcopenia, which is muscle mass and maintaining that lean muscle mass to allow you to function, to protect your joints, to keep you mobile. Tell us a little bit about sarcopenia, what it is, and how we can maybe prevent that from deteriorating as we get older.
Well, sarcopenia is a fancy medical word for loss of muscle mass and muscle strength relatedly, right? So over the course of a normal lifetime, even in the absence of a muscle disease, we lose muscle mass. And at some point, if we live to be 80, 90, or 100, which never happened 100 years ago or rarely happened, you would not have enough muscle mass to get out of the bathtub or to climb a set of stairs. But now we need those abilities. So it turns out that even modest amounts of exercise that improve muscle mass makes extraordinary difference. So we have studies now looking at older adults who are falling, for example. And if we do sort of low weight, very low weights, 5 or 10 pound weights, doing quadricep exercises or other exercises, high reps, we can improve muscle mass 1-2%. You might say to yourself, well, what's 1-2%? Well, at 90, if your life expectancy is another 5 years, that's 5 years of you ambulatory without a walker. I like to tell my patients it's like being on a cruise ship, and there's an iceberg way off in the distance, which is your aging. And if you just change the trajectory of the ship by 1% early enough, you miss the iceberg. And that's true of many aspects of caring for ourselves in our 40s, 50s, and 60s. You in your 40s and 50s and 60s are sort of a blueprint, for what you're going to look like later. I tell people, look at your parents who may have grown up in the 50s, 60s, or 70s when we didn't know about exercise and nutrition and ideal body weight, and they may be suffering from mobility problems or other issues. You could head that off. The idea is to live as long as possible with functional ability. I'm not interested, Ricky, in having people live to 110 to be bedbound or chair fast. That is as Pyrrhic a victory as a 40-year-old woman dying of breast cancer, right? We say in geriatrics, John Kennedy had this great quote, aging is not about adding years to life, it's about adding life to years.
I'm going to touch on that point definitely, before the end of our talk. When I see patients with spine conditions like spinal stenosis, first thing that comes up is family history. Did your parents have any disc disease or sciatica, things like that? And a lot of them say yes. And I tell them the difference is when your parents, again, in their 50s, 60s, 70s, 1950s, 60s, had back pain, they were probably told to have bed rest. Sleep in the bed, lay there for 2 weeks, 3 weeks, wait till things resolve, and then function. And then they developed kyphosis, and their posture got worse, and their bones got weaker. And now we know that's not the best treatment. We want you to get active as quickly as possible because we want to kind of head off some of these deleterious effects of long-term spine pain and joint pain. Going back to one of the things you said about muscle mass, I feel like a lot of patients, especially the elder adults, are afraid of resistance activities and lifting weights. They say, what was your exercise? I walk. And that might be enough. But they fear that they're going to hurt themselves by adding some resistance with TheraBands or weights or things like that. How do you address that with some of the patients who have those concerns?
Well, I have a bunch of favorite sayings, and you've heard me use them. Motion is lotion, and use it or lose it. Things in motion tend to stay in motion. And look, any kind of movement is better than no movement. I love your comment about bed rest. I mean, you and I trained in a period where the first order you wrote when you got admitted to the hospital was bed rest. Turns out that bed rest is one of the worst things you can do to patients. I'm going to go to the hospital and I'm going to get some bed rest. Well, whereupon you get bed sores, deconditioning, orthostatic blood pressure changes. That's a change in blood pressure when you go from lying to sitting. So We've now learned that even when you're in the ICU, we should be ambulating you to prevent the disuse. So human beings were meant to move. And I try to tell people to add even a small amount of resistance with TheraBands, with weights. And again, the goal here, Ricky, is that you don't have to swing for the fences. We're not looking for a home run or a grand slam. Again, it's that chip off in the distance that you're going to collide with. And if you could just change your trajectory by a half a degree, you're going to avoid that and live a life where you're not functionally impaired at the end of your life. The goal here, again, is not to die in a nursing home, chair fast or bedbound. The goal here is to go out bungee jumping, roller skating, having sex, whatever it is you like doing, as opposed to effectively living the end of your life with disability.
You know, it's interesting. Part of that order set that we grew up with in medical school and early residency was bed rest. And through physiatry training, you change that quickly to out of bed to chair for all meals, or out of bed to the edge of the bed, you know, with physical therapy. And just like you mentioned here at Weill, Cornell, New York, Presby, early mobilization in the ICUs is one of the key factors in getting patients out of the hospital to an acute bed and then eventually home and being functional with their families. What are some other tips that you tell your patients when you see that they are kind of heading down this slippery slope of decreased functionality, and you advise them on exercise? What about diet? What about sleep, stress management? What are some other strategies that you talk to about?
As I have gotten older myself in this business, Ricky, I first of all, the value of a good night's sleep. The data now on sleep and premature mortality and other problems is just incredible. You know, and if you look at diet, of course, you know, maintaining, you know, ideal body weight, maintaining mobility, is critical. The data on supplements and alternative therapies is kind of interesting. The most compelling data on complementary alternative therapy is not around supplements unless you have a specific nutritional deficiency. It's really around movement and mind-body sort of interventions. So yoga, tai chi, mindfulness. I've become a meditator in the last couple of years during the pandemic. Many people sought to that. And it's the meditation itself, but it's also the mindfulness that enables you to think about what you're eating, how much you're sleeping. So I've become a big believer in this. I'm an evidence-based doctor, you know, whether or not that treatment is a surgery or a medication or a supplement. And so when patients come to see me with reams of internet printouts about a particular supplement, I don't dismiss them. I say, let's learn about this together and see what the data is. Otherwise, they wind up having very expensive urine because essentially most of this stuff, Ricky, is just sort of peed out. But there's when patient has B12 or vitamin D deficiency, which we've seen a lot of during the pandemic because of people being sort of locked at home. It's a sunlight sort of related hormone. Then there's real benefit, particularly around mobility, muscle mass, falling, those kinds of things.
We've actually seen pretty good data in back pain literature on vitamin D specifically, and some of the lab values that are shown to be normal are probably lower than optimal. And with optimizing vitamin D levels, we've seen decreased fall risk, decreased fractures, more mobility, more functionality. But what are some of the things that patients are coming in and talking to you about? You know, it's such an unregulated field, supplements and osteobiflex and glucosamine and so many things for joint arthritides. Patients come in and say, should I try this? Should I try this? And I, like you, research it because I'm not familiar with some of these things. But what are some of the common supplements that patients bring into you to say, Doc, should I take this? Will it help me at all?
It changes every month, Ricky. A few years ago, it was ginkgo. There's compelling data that ginkgo for memory is not particularly useful. I'm sure you've seen the sort of chondroitin glucosamine business. Mixed data, not especially compelling in my view. Perhaps you disagree. I'm seeing vitamin B12. That's been a perennial sort of favorite, which is fine if you're B12 deficient, but most of those patients have B12s that are sort of through the roof. Vitamin D has made it, into the news. I will say that in the past year or two, I've seen sort of a pandemic of vitamin D deficiency on top of the pandemic and caused by the pandemic. So again, I have two concerns about patients. Well, three concerns. One is as it relates to supplements, they don't work. And that's okay if they're not harmful. The second is that they are harmful. I've seen patients be harmed by supplements, particularly when they interact with other medications, right? And the third is that they're costly. So I've seen patients literally unable to afford food because they were buying supplements that weren't particularly efficacious. I have my own theory about this, which is that the interest in supplements over the last decade or two is really a failure of medicine. It's really a failure of physicians, I think, to communicate. The medical world is so hurried these days. I feel like people are not being communicated with. They're not being doctored. When I say not doctored, I don't mean, listened to with a stethoscope. I mean, there's no sense of communication. And in my practice, and I have the luxury of spending lots of time with patients the way you do, I find that once I do spend time with patients, that stuff sort of goes away, right? But I'm always learning things from patients. Someone brought me a study last week, the use of peppermint oil for chemotherapy-induced nausea. And there was a randomized trial, and you know what? The data was pretty good. So, again, you and I are evidence-based physicians who want to see data, whether or not it's an injection, a surgery, or a supplement.
Right. It's interesting you brought up that the peppermint study. We actually did a study here last year on lavender aromatherapy on anxiety prior to procedures, and we found reasonable evidence that it does actually bring down anxiety. It prevents patients from aborting the procedure due to stress. Turmeric comes up a lot. I'm Indian. We cook a lot with curcumin or turmeric in our spices. And there's some compelling data to suggest that it can bring down inflammation in the body. It might lead to better joint health, better dementia protection, Alzheimer's protection, cardiac protection. Patients talk to you about turmeric at all? Where's your stance on that?
My wife buys turmeric coffee now, actually. Starbucks makes a turmeric coffee. I don't know if you're aware of this. And, I'm fine with it. People talk about it frequently. We know it to be safe. It's in our food. So I have no issue with that. The problem with these studies, Ricky, is sort of standardizing the dose. I'm a clinical trials person, so having two people with equal disease that are randomized who, so much of the information is anecdotal that people improve. And there are many other things going on. As people age, they might change their mobility. They may take other medications for pain. So it can be quite confounded, as the epidemiologists say. But if it's safe and if it's delicious, I got no problem with that.
So what do you do in your life? So you and I are we middle-aged? Where are we? We're kind of in the middle somewhere?
You would be
early middle?
You would be 40 is the newborn nursery. I'm 61, so I'm an adolescent.
So you're an adolescent. So what do you do with your life? What are you modifying in your day-to-day activities, your health, your diet? You mentioned yoga before, mindfulness. What are you doing?
I'm a huge fan of yoga. And this is a useful story. I actually, as you know, injured myself doing yoga. I got a little bit aggressive during the pandemic and tore not one but two medial menisci pretty severely. And so that was a message to me that you can overdo anything. You taught me that, and for which I'm immensely grateful. What do? I walk a great deal. I cycle now because I'm trying to decrease the amount of inflammation and sort of pounding on the joints. I'm trying to lose the 10 or 15 pounds I gained during the pandemic, somewhat successfully. And one thing we haven't talked about, I think that's incredibly compelling, is socialization. I saw, and I suspect you did too, lots of people who got sick during the pandemic because of social isolation. I mean, we are social animals, Ricky. Human beings are meant to be together. And geriatricians have long talked about this, and everyone sort of thought it was sort of tree hugging and kind of kumbaya. But, during the pandemic, I saw lots of people who became inactive, became depressed, missed their families, didn't take their medications, got into accelerated sarcopenia. It is a real thing. We just completed the most incredible natural experiment of inactivity and social isolation we're probably going to see in our lifetime. So I am always encouraging patients to interact. And if you can interact around exercise in a walking group or a pickleball group or whatever the sport is, what a terrific way to effectively, get yourself into better health. I realized that, during the pandemic, I did yoga with YouTube at my house, but in part what I was missing was the socialization and the friends of my studio. Those two things together are very, very compelling. Lots of the weight loss I saw during the pandemic was that people had no one to eat with. A meal is a nutritional event, but it's also a social event, right? So it's been a very interesting and instructive time that we're emerging from now in a very hopeful way, I think.
We also saw new diseases pop in or with more predominance during the COVID pandemic with a lot of upper back and neck pain, migraines. Usually I see more lower back pain, sciatica, but everyone was at home. They're working from home. They're Zooming. You and I are still Zooming with a lot of our meetings. So we're noticing diseases that we normally didn't see. But to your point on the elder adults not socializing with their family, yeah, you could see that in their face when you saw them. They haven't seen their grandkids in a year or 18 months. They haven't socialized with their friends. They haven't left the apartment. And that affected their muscle mass for sure, their nutrition, their functionality. And I'm optimistic. Most of New York, where we live, right here on the Upper East Side, majority of us are vaccinated. So I'm seeing kind of a resurgence of socialization, and hopefully that'll lead to a better outcome in our patients.
I also think, if we learned anything about mental health over the past year, it's the way that mental health colors our interpretations of our body. So, managing your arthritis is tough, but managing it when you're depressed, it's really a filter through which the pain is magnified. So we saw lots of depression and anxiety and problems that sort of magnified the health problems that people have to deal with. I mean, remembering to take your meds, is difficult for your heart failure, for your COPD, for your arthritis, but doing that when you're isolated and depressed and alone and sad, very, very difficult. So it's all connected.
And you and I just shared a patient story recently where we really had overlap in coordinating care. In the patients that you treat more so than I treat, there comes a point in life where the patient's primary social structure is their family member. And at times they lose their family members due to age and other illnesses. And now really they have no one. And that really affects their ability to participate in physical therapy, take their medications. And I actually leaned to you and I said, help me find some resources for some of my patients who actually have no one left in their life. And you really helped out. What kind of suggestions or offerings and resources do we have for patients that may have lost a loved one that needs some support?
Well, we're embarking on a big social experiment at our practice called the Center on Aging, in which we're really expanding the notion of a medical practice to kind of a social structure. So we're going to start doing classes on a variety of topics related to aging. I mean, Ricky, how do you make a new friend when you're 80 or 85, right? You make friends at work, you make friends, at school. Loneliness is really one of the most difficult diseases that, I treat. I see lots of loneliness. So we're talking now about sort of creating some kind of making new friends sort of club and making that part of the practice, because all this literature on the so-called social determinants of health, well, being isolated makes you more vulnerable to disease. If you become isolated, there's no one to detect that you're becoming short of breath. You languish alone in an apartment. So, in England now, I'm told that there's a part of the government that effectively deals with loneliness. And I think there's a ministry of loneliness, apparently. And I think, again, the pandemic has taught us that the mind and the body are incredibly connected. And I think that and of course, the great thing about many of the interventions I'm describing to you, they're safe and free. This is not chemotherapy we're talking about. This is something that can make you healthier, that is enjoyable and is non-toxic.
And I think that's where we could probably do a better job in Western medicine. We have great innovation, great technologies and interventions, but mental health and let's just get loneliness, we don't really talk about this a lot in medical training. We talk about doing what's cutting edge and what's going to impact someone's life in the short term. But how do we move this needle? I love what you're doing with the Center of Aging and a loneliness program. How can we work together better with our vast medical system here, our institution, to really get patients these resources that they need?
Well, I think it's old school. Ricky, back when 100 years ago, before we had MRIs and X-rays and fancy ultrasounds, which are terrific, someone came in off the farm with an injury. You had your physical diagnosis skills and your eyes to rely on. You could not be distracted by technology, right? You could not get an X-ray report that was, I came to you with a knee X-ray that was, as a physician, I was all depressed. I mean, look at this degeneration, and you taught me, and I should know this, that, let's not worry about what it says. Let's worry about how you feel and how you're moving. So I think it's effectively becoming a little less reliant on technology. On the other hand, technology with the ability to track our steps, to look at the so-called quantified self, as the techies say, gives us an opportunity to see how we're socially interacting, how much we walk. Because in the past, we just sort of gave the physician an estimate of I walked a mile today, I think. Now I know exactly how much I walked. So it's sort of integrating kind of old school, but also using the technology in a way that we don't become overly reliant. And, I think we've done a little bit of this to ourselves, Ricky. We've sort of overpromised in medicine that we can fix everything. Can't fix everything. Ultimately, every man has his time, and but we can have extraordinary quality of life until that time. And I think the hurried practice of medicine, it's why you and I work at a place like this where we're able to spend time and enjoy interactions with our patients. And I think the real hope is in the next generation of people that you and I train, right? I mean, these are people, I tell anybody who's really cynical about the world to come meet our residents, right? It would restore your faith in humanity. It's people who want to do the right thing for the right reason.
Yeah, I'm optimistic. I think, we can only do so much, but as physicians, we can shepherd our patients to living better lives and being more active, being more social. And a lot of the stuff that you, Dr. Lachs, have shared with us today can, be beneficial not just to the people listening, but also their family members. So sharing that with your loved ones and showing them how to be more engaged in their communities will definitely lead to better functional outcomes. The one thing you mentioned that I really want the listeners to take heed on is longevity is not the goal here. The goal is not to live to 110 or 120. The goal is not to add years to your life, but add life to your years. So I really appreciate you sharing your expertise with us on that topic. So where do we go from here? What's the next move for you and I? What can we really do to move the mark on health span and not necessarily lifespan?
Well, to try and convince people that there really is no free lunch, Ricky. I mean, every time I come to you, I want an injection, but you remind me, but no, you got to do those physical therapy exercises that, it's use it or lose it, right? That's true of your mind. That's true of your body. So you've got to partner with your physician. I tell people, you want to, find the best primary care provider, look in the mirror. I mean, if you believe that you can come to modern medicine and sort of lie down and just have them fix you, it ain't going to happen without your sort of ardent participation. And that's where you and I, our practices overlap. So I love when you email me those exercises. Yeah, I like getting injected, and having pain go away in a day or two or three. But really, there is no free lunch. You have to participate in your treatment, to learn about your chronic diseases, to take mastery of them, and to recognize that, although chronic disease is inevitable, by the time you're 75, people have on average between 2 and 3 chronic illnesses. Could be arthritis, hearing loss, hypertension. It's going to happen. The goal is, how do you remain independent and functional in the face of inevitable diagnoses that are going to crop up? I can say to you, Mr. Smith is an 85-year-old man with congestive heart failure, arthritis and prostate enlargement. And you cannot tell from that description whether or not Mr. Smith is a resident of a nursing home or the CEO of a Fortune 500 company, right? So we're going to get labels. The question is, how do we function with those labels? And the way to do that is to partner with your physician and be an active partner in your healthcare.
Definitely. Well, Dr. Lachs, I certainly appreciate it. I agree with a lot of what you said, if not everything, about being an active participant in your recovery and in your functionality. And I think if we can get patients to take some control of their lives and have us as their guide to help them in the right direction, I think that's where we have the best value. So thank you for taking time, spending it with me. I think we're going to look at some of your joints today anyway while you're here. And thank you out there to the listeners to tuning into the backstory, where just like we mentioned it before, we're not here to add years to your life, but add life to your years. And remember, when it comes to your health and when it comes to your spine, we've got your back. Thank you, everyone.
Thanks for listening to The Backstory. Please subscribe, rate the podcast, and review The Backstory on Apple Podcast, Spotify, and Google Play Music. And feel free to share this podcast on social media or even your own website or blog. This podcast is for general information purposes only. It does not constitute the practice of medicine, including the giving of medical advice. No doctor-patient relationship is formed. The use of this information is at the user's own risk. The content of this podcast is not intended to be a substitute for medical advice. To learn more about Dr. Singh and his clinical research, please follow him on social media. You can also sign up for his newsletter by going to www.rickysinghmd.com. That's RICKYSINGHMD.com.